So in this segment, we are going to have a look at the application of advanced modalities and see how we need to apply that according to healability and according to the mechanism of the modality that we are planning to use. So we are going to look at the rational use of adjunctive therapies in relation to healability, and just look at negative pressure wound therapy and hyperbaric oxygen therapy as examples and apply their mechanism, clinical effect into our clinical decision making. So if we look at healability, in healable wounds, we actually do not need to do advanced modalities because patients are usually balanced and stable enough that they are able to manage a healing trajectory on their own. In the non-healable wound, underlying causes cannot be corrected. So yes, they are in need of a modality, but it will not make any difference. Because those underlying causes that's not be able to correct it with an advanced modality, we will waste resources. Even in our maintenance wounds, those wounds we need to keep stable until we can get all of the system issues or the patient cause issues under control. They do heal over time. Maybe we can apply it, but most often in this category, it's also not applicable. But if we are going to the hard-to-heal situation patients, they are usually presenting late, and they are usually having underlying causes that was maybe diagnosed wrong, and maybe they were just from one team to another. Usually these patients are stable enough that they can do well with advanced modalities, and we can just give them a chance to do that again. So this is typically in the hard-to-heal wounds or those that have stalled and needs to have a kickstart to get them into healing again. Absolutely, yes. We are very much in favor of using it here. So let's look at topical negative pressure wound therapy. It's usually a non-invasive system where we are using subatmospheric pressure to achieve wound healing, and that is done by removal of fluid out of that space and connect that into a collection canister that is usually at the end of the line of whatever device you are using. The indications for them are diabetic foot wounds, pressure injuries, trauma wounds, dehisced surgical wounds, partial thickness wounds, flaps and grafts. The most important thing here is if you are having a patient with a critical ischemic wound, be extremely careful in the application of negative wound therapy, because remember, for the vacuum that needs to be created, there need to be an equal positive pressure applied to that wound bed. So if you are having a patient with an angiosome defect that we often see in our patients with diabetes, it may be that the blood supply arterial on the dorsalis pedis posterior tubule is okay, but because of an angiosome defect, there is limited supply in certain parts of the foot. And if we apply negative pressure on top of that, that amount of pressure can lead to tissue degeneration and tissue death in those patients. So make very, very sure about arterial supply before you do negative pressure wound therapy. So we need sufficient perfusion present at the wound site. Infection needs to be treated, and all infectant and devitalized tissue needed to be debrided away. So because we know in non-healable wounds we cannot do very much debridement because we are making a bigger deficit, negative wound therapy in the non-healable wound will not be an application of choice. And make sure that you have adequate local hemostasis, because the negative pressure can exsanguinate a patient if we are not careful. So what's the mechanisms that is part of this therapy? It creates a moist environment due to the occlusion. It gives a little bit of mechanical stretching. It deforms that extracellular matrix, and that causes a little bit of stress on that tissue, and that activates that cell proliferation, because then we have all of the transport genes and all of these nice things that need to come in, that is as part of the inflammatory process that we reactivates. We have edema reduction, meaning we are taking fluid out of the interstitial space, and that gives a little bit of relaxation on your capillaries. It creates a positive healing environment because it's very much enclosed, so it is protected from outside forces. Because of the reduction of edema, it has increased blood flow because the capillaries are a little bit more relaxed. And then we have all of these angiogenesis factors that is then stimulated, and that is mainly caused by that deformation that is happening on that wound bed and the little bit of stress that is applied there. So for a person with good arterial blood flow, but with a huge tissue deficit that needs to be covered, this is the ideal therapy. It needs to be managed by a person who knows what they are doing and know how to do safe application and removal. But as a modality, it has great effect in management of the diabetic foot. And there are ample evidence to also support that. If we look at hyperbaric oxygen therapy, that is not a therapy that we go into blindly. And we need to have a test that comes in between the diabetic foot management plan and the application of hyperbaric, and that is done with transcutaneous oximetry. Here I just want to differentiate. Your pulse oximeter that's going onto your finger measures oxygen that is bound to hemoglobin. Your transcutaneous oximetry, because we are using a probe, measures oxygen that is available directly to tissue. So it's two distinct measurements here. The one cannot do the other. So how does it work? Initially, it was used in neonates to correlate their arterial PO2 values and see if they are properly oxygenated, because their stratum corneum is so thin. We are using a special Clark electrode with a heating pad fixed to it, and then it comes into a seal-tight ring that is then attached to the lower limb. And that heating pad that you see on the top here increases to 45 degrees, and it causes a slight hyperemia and vasodilatation, and that allows for oxygen to transport through the skin into the little cup holder that's having a little bit of fluid in it that we are putting into that, and then it's absorbed into the membrane that is lying on top of the electrode, the Clark electrode. So it measures the oxygen supply that is available to tissue by diffusing the oxygen through the skin as a result of the hyperemia and vasodilatation. So we have a way to measure that. And if we are having patients with a 40 millimeter mercury blood supply that we then put on an oxygen challenge, and they do not saturate up to 200, but they do come into the region of a 100 millimeters mercury of measurement, they may be candidates to go into the hyperbaric. But we do this to make sure that we are not using the modality wrong, and that we are not wasting resources by putting patients patients in there that will have no benefit from that. So the Undersea Hyperbaric Medical Society have these 14 indications for hyperbaric oxygen therapy, of which those that are on the blocks are all those that having something to do with a wound. So that's the arterial insufficiencies, and that's what we are looking at with the diabetic foot. But we are also looking at the necrotizing soft tissue infections that we also get in the diabetic, and the clostridial myonecrosis, and sometimes even the crush injuries when the diabetic person is having an accident or a traumatic injury to that foot. So all of those plays very much into the diabetic foot. So yes, it does decrease bubble sizes. Remember, hyperbaric is actually for decompression illness and arterial gas embolism. So that's the mechanism that's helping the divers to recover. But for the sake of burns, we are looking at hyperoxygenation, meaning saturating the blood supply so that we actually have free flow oxygen going into the plasma. And that's very applicable in crush injury compartment syndromes and those with flaps and grafts. We also have vasoconstriction, again, crush injury compartment syndrome and thermal burns. But the beauty here is that we have fibroblast proliferation and angiogenesis factor that is happening as a result of that oxygen pool. And we are using that mechanism very, very much in the diabetic foot category, because they are slow with new vascularization, slow with granulation formation. And by giving a steep curve between tissue that is slightly hypoxic and an oversupply of oxygen, we suddenly get that pool of angiogenesis and granulation that is then taking place using beautiful energy to cover up that deficit. So I spoke about the angiogenesis. Also, we are potentiating antibiotic mechanisms here. And that's very applicable in the necrotizing soft tissue, refractory osteomyelitis, and in the problem wounds. And especially the antibiotics that is very prone for soft tissue and bone penetration, we can potentiate that to have even higher absorption into tissue. Reduce leukocyte adherence, lipid peroxidation, and then antibiotics synergy. And that is working together with that leukocyte oxidative killing. So hyperbaric in your real complicated diabetic foot that needs a lot of interventions and a lot of eyes on them is a wonderful modality to apply. We need to do it rational. It's best done if it's done by a team. It is best done if it's done for those that's having the best chance to succeed. And we need to be very sure that we are sure about dry eschars, especially with our negative pressure wound therapies, bleeding wound beds, or inadequate blood supplies. And then you need to balance. Maybe one modality is not applicable for the one, but the other one can compensate for the things that's actually contraindications in the other. Do not use adjunctive therapies non-optimal or suboptimal. Not only are you wasting money, but you can actually injure patients by doing that. So we don't want to do that. We want to do it on the point, the correct thing for the correct indication, and we want to do it with the least amount of adjunctive intervention we can. So this is what we have looked at, and how the mechanism and clinical effect can be related into the decision-making process when dealing with advanced wounds, especially like we can get with the diabetic foot that is having multiple comorbidities that is part of that equation. Thank you so much.